I think for most of us, if we hear the word rhinoplasty or colloquially a nose job, we have a very specific, almost dismissive cultural reflex.
Right.
We think of, celebrity gossip, we think of vanity, or maybe that one kid from high school who came back after summer break looking just a little different.
Right.
It feels like a luxury purchase, doesn't it? Like buying a handbag, but, for your face.
That is absolutely the common perception. It's so often dismissed as like the ultimate cosmetic fix.
Yeah.
But then you handed me this research, specifically the chapter on primary rhinoplasty from the medical text Plastic Surgery Key, and I just realized how wrong that is.
It's so wrong.
This isn't just about making something smaller or cuter. Not at all.
No. I mean, the text literally describes it as one of the most difficult and complex operations in plastic surgery. And when I started reading about the margins for error, we were talking about millimeters here. The text says results are measured in millimeters.
We are. And I think that's really the mission for this deep dive. We're going to try and strip away all that pop culture baggage to the nose job and actually look at the engineering and the psychology required to reconstruct the center of the human face.
Right.
Because when you look at the source material, you realize this is just a high-stakes collision of psychiatry, rigid geometry, and vascular anatomy.
And history, apparently. I was so surprised to see the text reference 500 BC. I didn't realize people were doing this back when we were still figuring out how to build basic structure.
That's where it starts. Sushruta in India. He was performing nasal reconstruction way back in 500 BC. It really puts it all in perspective.
Wow.
This wasn't originally about vanity, it was about restoration. And then you see it move through Europe in the 1800s with surgeons like von Graffe and Diefenbach. They were fixing noses lost to injury or disease or even punishment.
So it evolved from let's give this person a nose so they look human to let's give this person the perfect nose.
Exactly. It shifted from reconstruction to the refined aesthetic procedure we know today. But the core challenge, that hasn't changed. You're altering the central feature of human identity.
And you can't hide it.
You can't hide it. As the text points out, it's right in the middle of the face. You cannot hide a mistake.
That's the terrifying part to me. If a surgeon messes up a knee replacement, you might have a limp, but you can wear pants. If you have a millimeter deviation on your nose, the whole world sees it.
And the patient sees it every single time they look in the mirror. Which brings us to the first, and I'd argue the most important part of this text. I sort of assumed the chapter would start with anatomy, bones, cartilage, skin.
Right, physical stuff.
But it doesn't. It starts with the mind.
It has to, right?
Yeah.
The authors Roerich and Hawksworth, they state this so clearly. Emotional dissatisfaction often supersedes technical failure.
That is such a heavy sentence. It means you can perform a technically perfect surgery. The angles are right, the airflow is perfect, the scars are invisible, and the surgery can still be a total failure if the patient isn't happy.
So the first step isn't the scalpel at all, it's the screening.
It's the screening. They talk about functional versus cosmetic indications. Functional is, pretty easy to get.
Yeah, I broke my nose playing rugby, or I have a deviated septum and I just can't breathe. That's a repair job.
Right. Those are objective problems with objective solutions. The danger zone is the cosmetic side. This is where the surgeon has to basically become a psychiatrist. The text outlines these very specific red flags or danger signs.
Some of these were fascinatingly specific. The one that really stuck with me was the handheld mirror.
Ah, the mirror test.
It almost felt like a scene out of a movie.
It's a classic runaway signal for a surgeon.
But why is that such a red flag? Is it just vanity?
It's deeper than vanity. Think about how we normally see people. We see them in motion from a conversational distance, usually a few feet away.
Yep.
If a patient comes in, pulls out a magnifying mirror, and starts pointing out some tiny asymmetrical bump that is literally invisible to your naked eye, that's a problem.
Because they're not seeing their whole face. They're just seeing this landscape of pores.
Exactly. They're obsessing over minutia. It suggests an obsession with a level of perfection that surgery just can't deliver. Surgery improves, it doesn't perfect. And if someone is fixated on a flaw that doesn't really exist to the outside world, that's a huge sign of body dysmorphic disorder.
The text actually uses a specific acronym for the highest risk patient. I feel like medical fields always have these dark little acronyms, but this one was brutal. Simon.
Single, immature, male, overly narcissistic.
It feels incredibly specific to just call out single males. Why them?
It is specific, but the text makes it clear it comes from decades of data. They identify this demographic as being really high risk because they, historically, have the most unrealistic expectations.
So they see the surgery as a way to fix their whole life, not just their nose.
Precisely. It's that kind of magical thinking, like if I get this nose, I'll get the promotion, or I'll finally get the date.
And when they get the new nose, but they don't get the promotion.
They blame the surgeon. The text warns that these patients can be litigious or even violent. They're looking for an external fix to a deeply internal problem.
There was a graph described in the chapter that I found really helpful to visualize this. It plots degree of deformity against patient concern.
The graph of concern. Yeah, this is a mental model every surgeon uses. Imagine a chart. On the vertical axis, you have how messed up the nose actually is, objectively.
Yeah.
A massive hump, a crooked twist from a car accident, something obvious.
Okay.
And on the horizontal axis, you have how upset the patient is about it.
So if my nose is smashed sideways and I'm really upset about it, I'm in the clear.
You're in the safe zone. Your concern matches the reality of the deformity.
Okay.
The danger zone is the bottom right of that graph.
Right.
A minimal, tiny deformity, maybe a 1 millimeter bump, but maximum concern. The patient is absolutely devastated by this tiny little thing.
And the text says surgeons should basically just run away from those patients.
Ethically, yes, you have to decline. The text has a golden rule here. Do not operate on a patient you don't like. If you can't forge a relationship, or if they're hostile toward previous doctors, which is another huge red flag, you just do not pick up the knife.
Okay, so let's say the patient passes the test. They're not a Simon, they aren't carrying a magnifying mirror, they're psychologically cleared for takeoff.
Right.
Now we move from the psychiatrist's couch to the architect's table. Because reading this, I realized rhinoplasty is basically just geometry on a curved surface.
It's pure facial analysis. And you can't just look at the nose in isolation. That is the Ricky mistake. You have to start with the rule of thirds.
Okay, walk me through this. How are we dividing the face?
Horizontally. So you divide the face into 3 equal sections, from your hairline down to your eyebrows.
Okay, section 1.
Then from your eyebrows to the base of your nose. And then from the base of your nose to the bottom of your chin.
And in an ideal world, those 3 sections are all the same height.
Ideally, yes. If that middle third, the nose section, is way longer or shorter, the face just looks unbalanced. So the surgeon measures that first. But then you zoom in on the nose, and the geometry gets Well, kind of poetic. Did you catch the seagull reference?
I did. It said the bottom of the nose should look like a seagull in gentle flight, which is a lovely image, but what does it actually mean, surgically?
Okay, so imagine you're looking up at someone's nostrils from below. That's the basal view.
Right.
The seagull is the curve of the outer rims, the edges of the nostrils, and the columella, that strip of skin in the middle.
Okay, I can see it.
It shouldn't be a flat line. It shouldn't be a sharp V. It should have this gentle winged curve. The columella dips down a tiny bit, and the nostril rims curve up like wings. If that curve is too steep, you look startled. Too flat, and the nose looks heavy and wide.
And achieving that gentle flight involves stitching cartilage that's under tension. It sounds incredibly difficult.
It is. But we aren't just trusting our eyes. We're using protractors. This is where the text gets into the specific angles. And this blew my mind. The difference between a male and a female nose can come down to about 4 degrees.
This is the nasofrontal angle, right? The dip between the forehead and the nose.
Correct. If you run your finger down your forehead, right where it dips in before the nose starts, that's the nation. The angle of that transition is critical. The text says for females, the ideal angle is 134 degrees. For males, it's 130 degrees.
This seems so subtle. 4 degrees. I feel like I could change that just by raising my eyebrows.
It is subtle, but our perception is incredibly sensitive to these things. A 134-degree angle is smoother, a bit more open. It makes the nose look slightly shorter, more delicate. The 130-degree angle is sharper, deeper. It gives the nose a stronger start, which we culturally read as masculine.
And then there's the tip rotation, the nasolabial angle.
This is the one people notice most. It's the angle between your upper lip and the bottom of your nose.
Basically how upturned it is.
Exactly. For women, the ideal is 103 to 105 degrees. That's a rotated, slightly upturned tip. It's seen as useful and feminine. For men, 95 to 100 degrees.
Just basically a right angle.
Almost.
Yeah.
If you rotate a man's nose to 105 degrees and give him a piggy look, it feminizes the face instantly.
Yeah.
But on the other hand, if a woman's nose is at 90 degrees, it could look droopy or aged, especially when she smiles.
It's just wild that our brains are these supercomputers that instantly calculate these angles and then output judgments like attractive or tired or masculine without us even knowing why.
And the surgeon has to reverse engineer that subconscious perception using cartilage grafts and sutures. It's amazing.
Okay, so we've got psychological clearance, we've got the geometric blueprint, now we have to actually build the thing. And this is where the text shifted from architect to, I don't know, almost like bomb disposal unit. The anatomy section made me realize how risky this all is.
It's incredibly high risk. You're working with a canvas that fights back. The text spends a lot of time on what it calls the skin soft tissue envelope.
Which is just a fancy way of saying skin, but they make a huge deal about skin thickness. I always assumed skin was just skin.
It's the #1 variable the surgeon cannot change. You can cut bone, you can trim cartilage, but you are stuck with the skin the patient walks in with. And the text describes thin skin as unforgiving.
Why is thin skin worse? I would have thought thin skin would be good because it's delicate.
Think of it like a bed sheet. If you have a mattress with a bunch of lumps and springs poking out and you put a thin silk sheet over it, what do you see?
Every single lump.
Exactly. Thin skin acts like shrink wrap. If the surgeon leaves one tiny sharp edge on a bone or a little irregularity in the cartilage at the tip, that thin skin will just drape right over it and highlight it for everyone to see. The margin for error is effectively zero.
Okay, so then thick skin must be better.
No, thick skin has the exact opposite problem. Think of a heavy wool blanket. You could carve the most beautiful, refined, delicate nose structure underneath, like a Michelangelo statue. But if you throw a heavy wool blanket over it,
You see nothing, it just looks like a lump.
it just looks like a blob. Thick sebaceous skin hides all the definition. So the surgeon has to be much more aggressive just to get any definition to show through. Plus, the text notes that thick skin holds on to fluid edema for much, much longer. These patients can stay swollen for months, sometimes over a year.
So you're fighting the material itself, but you're also navigating a minefield of blood vessels. I really didn't realize the blood supply to the nose was so precarious.
It's surprisingly fragile. The nose gets its blood from 2 main sources: the lateral nasal arteries coming in from the sides and the columella branches coming up from the lip area.
And the text focuses heavily on open rhinoplasty. That's where they make an incision to lift the skin up, right?
Yes, in a closed rhinoplasty, all the cuts are inside the nostrils. But for really complex work, surgeons prefer open. They make what's called a transcolumella incision, a little stair-step cut right across the skin between your nostrils, and they peel the skin back to see everything.
But wait, if you cut across that strip of skin, don't you cut those arteries coming up from the lip?
You do. The text explicitly states it. The transcolumella incision severs the columella arteries.
So you've just cut off half the fuel supply to the tip.
You have.
Yeah.
Usually that's fine. The lateral arteries on the sides are robust enough to keep the tip alive. It's a redundant system. But here's the bomb squad moment I was alluding to.
The danger zones.
Exactly. Sometimes a surgeon wants to make the nostrils narrower. It's called an alar base resection. They cut little wedges out of the sides of the nostrils. But the text warns, if you cut too high up into that alar groove.
You hit the lateral arteries?
Yes. And if you're doing an open rhinoplasty where you've already cut the bottom supply, and then you aggressively cut the sides, severing the lateral supply,
We've cut everything.
you have isolated the nasal tip from his blood supply.
Which means?
Tissue death. Necrosis. The tip of the nose turns black and dies. It is a catastrophic, disfiguring complication.
That is terrifying. It really drives home why the authors emphasize understanding anatomy so deeply. You can't just hack away at things.
You have to respect the biology. There's another dynamic element mentioned too, the muscles. Did the depressor septinacci stand out to you?
The smiling muscle.
Yeah.
Yeah, the text says this muscle can pull the nose down.
We've all seen this. Someone has a nose that looks perfectly straight when their face is resting. But as soon as they smile, the tip of their nose just dives downward.
It droops.
That's the depressor septinacci muscle being hyperactive. It's tethered to the tip. The text suggests that during the surgery, the surgeon might need to actually cut or transpose this muscle to release that tether.
So they're literally disconnecting the nose from the smile mechanism so it stays perky.
In a way, yes. It's about thinking in 4D.
Uh-huh.
You aren't just sculpting a static statue. You are engineering a moving part.
We touched on the angles for men versus women, but the text really devotes a big section to the structural differences. It seems like a major pitfall is treating a male nose like a female nose.
Oh, that's the cardinal sin of rhinoplasty. You cannot use the same techniques. We talked about rotation, but let's talk about the profile, the dorsum.
The bridge of the nose.
Right. For a woman, the text says the aesthetic ideal is for the dorsum to lie about 2 millimeters behind a straight line, drawn from the root to the tip.
So a slight scoop, a little concave slope.
Very slight. You don't want a ski slope, just a gentle curve. And it should end in what they call a superfit break.
That sounds like a bone fracture, but it's actually a good thing.
It is. It's a subtle dip just above the actual tip of the nose. It catches the light, and it gives the tip definition. It separates the bridge from the tip. In women, this is highly desirable.
For men?
None of that. A man's bridge should be straighter and higher. It should approach that straight line, not scoop behind it, and there should be no super tip break. The transition from bridge to tip should be smooth.
Because if you give a man that scoop and a defined tip break,
You feminize him, you make the nose look cute rather than strong. And there's one other feature that balances the male nose, the chin.
I was surprised to see chin implants mentioned in a chapter about nose surgery.
It's all about balance. A strong nose needs a strong chin. If a man has a large nose but a weak receding chin, the nose looks even bigger. It completely dominates the face. So the text advises that surgeons often need to recommend a chin implant along with the rhinoplasty to actually balance the whole profile.
It's fascinating. You go in for a nose job and you might wake up with a new chin because the geometry demanded it.
That's the difference between a technician and a true surgeon. A technician fixes the part, a surgeon balances the system.
So we've covered the psychology of the Simon patient, the geometry of the Siegel, the danger of the blood supply, and the art of gender balance. When you step back and look at this chapter as a whole, what's the one big thing you want people to take away from this?
For me, it comes down to one phrase the authors use: virginal tissue.
The initial operation is critical.
Yes, the authors emphasize that the first time a surgeon opens a nose, the primary rhinoplasty, that is the golden opportunity, the anatomy is normal, the tissue planes are clear, the cartilage hasn't been warped by scar tissue yet.
It's the only time the map actually matches the territory.
Exactly. Once you operate on that nose, it is forever changed. It becomes a landscape of scar tissue and altered blood flow. Secondary or revision rhinoplasty is exponentially harder. The success rates plummet and the risks go way up.
So the message is, get it right the first time.
The message is, plan, measure, screen the patient, and if you aren't 100% confident, don't operate, because you are using up that patient's one and only chance at a virginal result.
That really puts the pressure on that initial consultation. It's not just about booking a surgery slide. It's about deciding if you're willing to alter someone's identity permanently.
And doing it all through a keyhole incision while making sure they can still breathe.
It really changes how I look at the whole procedure. It's not just vanity. It's this wild combination of engineering and art.
It really is.
I want to leave everyone with a thought that really stuck with me from reading this. We talked about those angles, 130 degrees versus 134. We talked about the bridge being 2 millimeters behind the line.
Millimeters and degrees.
It makes you think about the fragility of our own self-image. We walk around feeling like I am me. But the difference between looking like you and looking like a stranger, or the difference between a masculine face and a feminine face, is literally 2 millimeters of cartilage.
It is. A tiny sliver of tissue determines whether someone looks in the mirror and sees confidence or sees a delusional distortion. It is a powerful reminder of how subtle and how powerful human perception really is.
And how incredibly skilled these surgeons have to be to navigate that. Thanks for joining us on this deep dive into the geometry of the nose.
My pleasure.
We'll see you next time. Keep exploring.